Okay, so this is what I hope to talk about today, and I'd prefer this to be as interactive as possible. If you have questions along the way, that does not bother me. Just raise your hand and we can talk. I'd like to talk about exacerbations a bit. We're going to use the GOLD guidelines. You've heard those come up a lot, and that's because that should be the backbone for everything you do with your COPD patients. It's not a mystery on how to treat these patients. We've got a lot of research, and it's really accessible research. So we're going to use those standards and how we treat our exacerbations, but we're also going to talk about what that patient really looks like when they show up at your clinic, because that's really what matters. We're going to talk about the GOLD guidelines have a lot of non-pharmacological treatment recommendations, and we're going to talk about those. And then we're going to spend a lot of time on, hopefully a lot of time on durable medical equipment, because I think that's a real point of contention. So managing exacerbations. It's probably one of the most expensive and time-consuming things that we have to deal with regarding COPD. They interact with a lot of systems when they're having an exacerbation. They can call your clinic, they're going to the emergency room, they're in the hospital, they're using a lot of resources at discharge, home care. And so we need to recognize the importance of the exacerbations and also how we can help treat those. We know the biggest factors for that are probably going to be infection. And then this just talks about how we're treating those exacerbations with short-acting inhalers. So there's a piece here on non-invasive ventilation. Who's heard of non-invasive ventilation? Interesting, good to know. All right, so non-invasive ventilation. So who's heard of sleep disorder breathing? Okay, so we have patients that are on CPAP machines. We have patients that are on BiPAP machines at home for sleep apnea. Non-invasive ventilation is a similar use of the type of equipment that you see with sleep disorder breathing, but it's for patients that have that higher carbon dioxide level, that have COPD, and we're trying to help manage that. So when you see people that are in the hospital and they're put on non-invasive ventilation, it's referring to this, I'll try to show you a picture as well, but it's referring to a machine that basically helps your patient take a deeper breath, okay? That's really what it's about. The patient with COPD has a hard time inhaling and exhaling. This machine helps them with a mask in the hospital setting, take in a deeper breath than they would normally be able to do, and then exhale more effectively, which in turn decreases their carbon dioxide. It's a very simplified version of what it does, but that's basically what it does. And that's used a lot. It's used a lot because it's non-invasive. We used to, when a person would go into the hospital with an exacerbation many years ago, one of the first things we do is just, sedate and intubate, and that's just not the plan anymore, right? We want to keep these patients treated as non-invasively as possible. So indications for the hospital assessment. Again, this is from the GOLD guidelines, and you're going to see that you can pull these slides up for your own personal use at any point from their website. The things that you're looking at for hospitalization are their symptoms getting worse, higher respiratory rate, decreased oxygen saturation, acute respiratory failure, obviously. One of the things I want to point out is the insufficient home support. So we're from CareOregon. We have a lot of patients that don't have great home support, and that has to be part of our process when we're thinking about whether or not they can be managed at home. The patient that has a full family support system and a nice house and all the things they need are going to be able to stay at home, maybe longer than a patient that has almost no living conditions or very poor living conditions. Maybe they don't have electricity, maybe they don't have anyone there to help them manage their medications, which gets more difficult with COPD the more confused you get. And so those patients you have to look at a little bit differently. So knowing those things about your patient will be helpful. So what are you going to see? So this is actually what is helpful, I think. What are you going to see when your patient comes to the clinic or calls the clinic? So how many nurses are in the room? So are you guys the people who answer the phone usually at your clinics? Are you the people that triage? Is that typically the role? Okay. How many providers do we have? So within your clinic, if a person with COPD calls, is it normally going to be triaged by a medical assistant and then sent to a nurse? How does that work? Anybody? So that call will go directly to a nurse? Is that pretty much the case for everybody? medical assistant? Okay. So this can be a very intimidating phone call to get because if you're not really comfortable with COPD and somebody calls and says, I can't breathe, I'm short of breath, I can't breathe, the first thing you want to do is say, go to the emergency room. I mean, and that's not that that's a bad instinct, but it may not necessarily be what the patient needs. But it's very difficult unless you really increase the comfort level of the person answering the phone for that not to be the answer. You know, so our goal is to help you see what kind of things people are going to call with, what kind of things are the most important that you should really pay attention to right away, and what kind of things you can continue to have a conversation with the patient about. So the things that people will do when they have an exacerbation are turning up their oxygen. So if the patient already has oxygen, I'm sorry, I'm going to grab some water real quick. Can you grab my water? If the patient already has oxygen, it seems like the thing that people want to do if they get short of breath is to turn it up, you know, which makes sense. If you can't breathe, you know, you want more oxygen. But we all know that that's not the best thing for the patient and often can be detrimental. So paying attention to that, knowing what their leader flow is. One of the things that I see, and I point out a lot of things that I see just because I feel like that's helpful in real life. One of the things I see often is that nobody knows what the prescription is for the oxygen, right? We all know the patient's own oxygen, but that prescription gets really vague. Like sometimes it's ordered by the hospital, sometimes the home care company sends something that you sign that has a prescription on it, and it never actually is part of the medical record. So knowing what your patient is supposed to be on and having that easily accessible to the person that's answering the phone calls will be helpful. Because if a person is supposed to be on 2, they might not even know that. You know, so they may think their baseline is supposed to be 3, and they've now turned it up to 5. And that will happen on a pretty regular basis. But if your person answering the phone doesn't know what the prescription is and doesn't have easy access to that, then that can be difficult for them to determine whether that's a red flag. They'll use their bronchodilators more often. You know, so again, going back to if you have a patient that is using their rescue inhaler, say you did their education last time they were in 2 months ago, they're using their rescue inhaler 2 or 3 times a day, which is kind of common. If they call with shortness of breath, you can ask the question, how many times are you using your rescue inhaler? They're going to answer you with, you know, a different number possibly, right? I'm using it 8 times a day, 10 times a day. I'm having to wake up at night and use it. That's a big difference, and you want to know that. But without knowing what their baseline is, it's a little hard to, and you can't go by the prescription only as their baseline. So if their baseline, or if their prescription is every 4 hours as needed, that doesn't necessarily mean that's how they've been taking it. You know, so it's really important to ask those questions. Sputum production will change. And again, you know, everything I think with COPD is so much about what their baseline is, right? So some people are going to have thick green sputum all the time, and that's just what they live with. So that's their baseline. Some people are clear, you know, and every morning they wake up, they cough up clear sputum, and they're fine for the day. Knowing what their baseline is how you determine whether an exacerbation is happening. So if they call you and say, now I'm waking up at night and I'm coughing more, that may not seem like a big deal, but it can be a very big deal. It can mean a lot of things. It can mean fluid overload. It can mean, you know, that they're just getting a pneumonia. It can mean that they're just getting an infection. It could be a lot of different things. That increased cough and increased sputum production is one of the first things that will start to change. More shortness of breath at night is a really common thing that I think we overlook sleep in general, you know, as a community. But people will talk about that they used to only wake up once at night to take their nebulizer, and now they're 2 or 3 times a night taking their nebulizer. That's a red flag. We want to pay attention to that. And then unusual sleepiness or confusion, and headaches and blurry vision. So you have these in your handouts, and there's actually 2 slides with it on there. These are questions that you can actually ask, and you can use these, not copyrighted. You can use these, and I would just have you be really, you know, careful that when you're asking these questions that you have a path for the person to deal with the answers. You know, that your clinic has already kind of figured out how you want to deal with what answers they get. Can the patient talk in complete sentences? This is the only one that's in order. Okay, the rest of them are not in any particular order. But if your patient can't talk in complete sentences, they should just tell them to call 911. That's not a time to spend on the phone trying to figure things out. If you can talk to your patient, though, this is how I would recommend that the conversation go. So you want to find out when things started, right? You want to know, did this start today? Or did this start a week ago when your niece came over and had a cold, and slowly you've been getting progressively worse? We can almost nail down that there's probably an infection happening if we know that this person was exposed and they've slowly had symptoms. We know what's happening with that most likely. But if their symptoms just started today, that's a different thing, and we want to address that a little bit differently. Have there been any changes in your cough? What we just talked about. Are you currently taking prednisone? And it's really important that you don't just ask that first part. So what's your dose, and did you take it today? Because a lot of times people we know get discharged from the hospital with a prednisone order, and they just never get it, they never take it, they never finish it, they don't like the way it makes them feel, so they just stop taking it. So, you know, getting really digging in deeply to the prednisone. Also things like, did you just stop a prednisone taper? You know, because if you were on prednisone, doing well, and then you just stopped it, that could be, you know, part of the reason that this is happening. So we want to know that. And then tell me what inhalers you've taken today. It's going to be really hard with a person over the phone to do this because you're going to say, what inhalers did you take? I took all my inhalers. I'm fine. I took all my inhalers. None of them worked. That's what they're going to say a lot of times because they're annoyed because they can't breathe and you're trying to make them talk about it over the phone. But you can't, the fastest way to help them is to find out if they took the right inhalers, right? Because if you know that they didn't, you can at least direct them to that even if you're still going to do other things. It doesn't mean you're not going to do anything else, and it's really important that the patient understand that. We're just trying to do the fastest thing first, right? And if we know that they accidentally took the wrong inhaler, we can tell them which one to take and direct that, even if we do more. Have you missed any doses of your inhalers? And how often have you used your rescue inhaler in the past 24 hours? We talked about that. Do you use a spacer with your rescue inhaler? They're going to say no, because nobody uses spacers, it feels like. Some people will have a spacer, and if they do, you really want to encourage them to use that with their inhaler. Okay? We know that very little, there are videos, a million videos of people taking inhalers without spacers. There's posters of people taking inhalers without spacers. And that's, I think, possibly because of copyright issues with the posters. I don't know why it's like that, but you have to explain to people that they have to use that spacer with that older style inhaler, or they really don't get any of the medication. What happens then is that they use so much of it that they run out before their prescription is due to be refilled, which is a huge problem. You know, some people are using 4 or 5 full inhalers in a month, and that's really excessive, and we can almost be sure that they're probably not getting the medication if they're using it that quickly. The part about the counter on the back, you know, most inhalers now have some sort of counter. There is a few, I'm not sure if I'm allowed to say it. I think the Prevenal inhaler still does not have a counter on it the last time I checked. Is that still true? But most rescue inhalers are going to have a counter, but they're not visible. They're not super easy to read. You know, I mean, they're very small, especially on the older inhalers, and people take those empty inhalers for a long period of time after they go out. So you can still puff those. It still looks like medication is coming out, but there's no medication in that after when the counter says 0, you can assume that there's medication left, even though it looks like things are coming out. It's a very important thing to tell patients every time you talk to them about their rescue inhaler. But there are, the situation in the home is this, and some of you may have done home care, so I'm hopefully not repeating something you know, but the situation in the home is this. There are 4 or 5 or 7 rescue inhalers laying around everywhere. Some of them have medication, some don't. And if they can't see the counter, you know, that's a big risk. So one of the things I do and other people that go into the home is try to like consolidate that, get it down to where they just have the medication that they're supposed to use. But having that conversation and helping them understand that once it's on 0, they need to throw it away. Because if they keep it around, even if there's like 1 or 2 doses left, they keep it around, they use it when it's empty. And we see those people going to the emergency room. So do you have a nebulizer? Dr. Cummings talked about nebulizers a bit. And the reason that I will recommend a nebulizer for people is if they're going to the emergency room and taking neb treatments, and that's the thing in the emergency room that's helping them get better, there's almost no reason that they can't have that in the home if it's effective and their provider agrees. It's a very inexpensive piece of equipment for CareOregon to provide, and it's very effective for some people. And if they're going to the emergency room and taking nebulizers and prednisone and then coming back home, these are all things we can do in the home. And it just decreases their exposure. On nebulizers, I just want to also say this really fast. We do have the option for portable nebulizers that are battery powered. You know, they're really good for people that are mobile, that do a lot, that are out in the community a lot doing things, and they need their nebulizer for some reason versus an inhaler. They are not great for your homeless population, unfortunately. I mean, they're an option for the homeless population, but they are they tend to get stolen. You know, they're hard to keep up with. They're kind of what appear to be an expensive piece of equipment. So maybe not always your best resource there, but it is a possibility. We talked about that. A lot of people now have pulse oximeters. So when I have here, do you have a monitor to check your oxygen level? People can buy those for like $30 now, and so they do. You know, sometimes the insurance will cover it as well, but many people just buy those. And so you can ask them if they have it, and oftentimes they will, and they'll check it for you and tell you what it is, which is really nice. So don't be afraid to ask people that question, and don't be afraid to order it for your patients that need it. The only criteria that I'm aware of for this is that they have to have oxygen prescribed, and it has to be, they have to be able to need to titrate it themselves. So it just has to have in the notes that they are on oxygen and that there's a need for them to be able to go up and down on their oxygen level according to their saturations. That can be a really valuable tool for some patients, and it's really small, right? It's just a little one that goes over their finger. It's not a big one. It can be a great tool for some people. It can be a really poor tool for others. You know, so you're just going to have to know your patient and decide whether or not that would be helpful for them or if it will drive them crazy. Because some people will just look at it all the time and get a little obsessed with it. So, you know, you have to use your judgment on that, but it can be a really good tool. So do you have a BiPAP machine that you wear at night? So a lot of COPD patients are going to have, halfway already? Oh, I got so much to say. All right, so a lot of patients that have COPD are going to have, possibly already have a CPAP machine at home. Maybe they had it for sleep apnea. Even maybe they've had it for years and years and years. That is not necessarily going to help them when they're short of breath. Okay, so that CPAP machine is there for sleep apnea. It's not necessarily going to help them when they're in a situation where they're short of breath. But a patient that has a BiPAP machine can get either a BiPAP machine because they're using it for purely a sleep disorder breathing reason, or they maybe have it for their COPD. For whatever reason, that BiPAP machine will help them when they're short of breath. It will help them immediately in the moment. It's one of the things we do when they go to the emergency room. So if they have a BiPAP machine and they are comfortable putting that on, even if it's just a bridge until you figure out the next thing to do, that can be a really good resource. So does anybody have questions about these? You guys will have copies of these. If you want to use them in your clinic, you can. Add to them, take away from them. And like I said, they're not necessarily in order. So if you do use them, you can kind of create a flow. That would work for you guys.
Does the BiPAP, sorry, we can hear you.
I'll repeat it. Go ahead.
Does the BiPAP reduce the inflammatory markers?
The BiPAP is going to reduce their carbon dioxide. Is that what you're asking?
Yeah, their inflammatory process.
So not necessarily.
No. BiPAP really is used to help with the patient's excessive work of breathing, and that's really the primary use of it. I mean, there are a lot of patients with COPD with chronic CO2 retention, right? Not all of those will need BiPAP, but when they're working hard to breathe and they're hypoventilating relative to what their baseline is, that's when it's indicated. But no, in fact, if you look at mechanical ventilation, there's an increase in inflammatory markers. So when you're giving positive pressure, there's more stretch than what you normally have. You're going to have an increase in some of the inflammatory markers and cytokines.
So that is all about exacerbations. If anybody has any questions about that, now is your moment. I'm going to move forward. So, oh, no, it's not. I lied. These are slides that you might use in your, I'm not going to spend a lot of time on these, but these are slides you can use in your clinic if you want to. They talk about what you should do in your 1 to 4 week follow-up, which are, so this is post-hospital discharge, right? Your patients that go in for COPD, you want to do a 1 to 4 week follow-up and then also a 12 to 16 week follow-up. That's ideal. And these are the things that you would want to cover during that. empty inhaler usage. We talked about that. Okay. So next section is on back to the gold standards. When you look at the gold standards, these are all the things that they're saying are important as far as non-pharmacological treatments. Education and self-management, physical activity, pulmonary rehab, exercise training, and self-management education are all covered during pulmonary rehab. So the reason we have it circled is because you can really capture a big portion of what the gold recommendations are just by sending your patient to pulmonary rehab. You literally don't have to think about it again after that. They do an excellent job. It's what they do, and they are really good at it. And we have a lot of resources for that in the community, and it's paid for by their insurance, and it's part of medical transportation. So if your patient doesn't have transportation to get there, it can be covered through that. So if they are willing to go, this is one of your best resources. Just to cover the other 4 really quickly, palliative care, I'm not going to talk about that. Nutritional support. Yeah, go ahead.
Briefly about how to describe to a patient what will happen if they go to pulmonary rehab?
I'm going to show you a video of patients talking about pulmonary rehab, which is so effective that I think it's better than what I can say. But yes, we can also talk about it more, for sure. The nutritional support, I want to say that people don't eat as well as we think they do. So when I go in people's homes and talk to them about what they're eating, and I say specifically, tell me what you ate yesterday, not tell me what you ideally eat. But what did you eat yesterday? What did you eat today? That's so little. People don't eat enough food, and they don't eat with their medications when they take them. They take a handful of pills on an empty stomach, and they don't have any appetite, oftentimes probably because their stomach is full of medications, and their diet is just poor. And that's the worst thing we could do for a COPD patient. They need a higher caloric intake. And so please remember that we do have options to help these patients nutritionally if they have to meet criteria. And Mariah talked about that a bit. And you don't have to remember the criteria. Just reach out to CareOregon whenever you feel like that's a thing that you want to work out for your clinic. And eventually, you'll get used to ordering it. You'll know the criteria. But please use that because people don't know that it's available, and patients are pretty willing, even though it's not that great. And then oxygen therapy and vaccinations. I'm only going to go over one piece of this slide, and that is the...
Heather?
Yes?
I have one question.
Oh, sure.
Sorry. I was curious about with the part about exercise, if on the back end of things, if you were looking to see what a provider was doing to support a COPD patient's exercise regimen, what would you want to see ideally?
Just having a conversation about it is probably one of the things that, and setting small goals. I think people that aren't in pulmonary rehab tend to, one of the things I like about pulmonary rehab is they bring it down to the place where the patient is at, and they slowly build them up. People want to believe that they can do more than they can when they're doing it on their own. So they set these unrealistic goals and then fail and feel bad about themselves because so much of COPD is guilt-driven. I mean, everything about COPD is wrapped up in guilt. Guilt about smoking, guilt about not taking your medications, guilt about not using your BiPAP machine, guilt about not using your oxygen. All these things are guilt, providing, and we don't want that piece of it. So just trying to help people set realistic goals and then following up with what those were. You're not going to walk a mile. Can you walk down your hall and back? That's a realistic goal. Yeah.
For pulmonary rehab, it has really good evidence. And there was a mention that it was even as effective as inhalers. But in real life, I think what we have a problem with is connecting patients to pulmonary rehab. I do referrals all the time, and rarely does anyone ever go.
Okay.
I don't make it from the time that I talk to them about it, do the referral, and end up in a clinic. So just explaining where pulmonary rehab happens, and can it happen in the home? Are there group visits available? Is there some way to make access to pulmonary rehab easier for our patients?
Right. Those are.
I can maybe field that question. The question is basically, how do we get more patients involved in pulmonary rehab, and where does that happen? So pulmonary rehabilitation is basically a gym class that occurs somewhere in a medical facility that's run by those types of physical therapists that understand either heart failure or severe lung disease. And so they're able to tune into some of the limitations that those patients might have. So you know, whenever I have a patient that is not doing any exercise at all, which is quite frequently, I'll ask them why not. A lot of times they'll say, well, I've been told because it's not any good. But what I then tell them is that there's not a lung disease or heart disease that I can think of that I'm going to tell you not to exercise. So then I explain to them this is an exercise class that takes place. It's going to be about 12 visits. Sometimes they'll be honest and just say, I'm not going to go. And then I'll say, well, what other exercise can you do at home 3 times a week? Or do you have access to a YMCA that's close? So you can use any type of exercise. It doesn't have to be pulmonary rehab. But if the patient's willing to go and they have a pretty severe limitation, they're going to have to become more comfortable with relearning how to exercise.
Did that answer? Alford?
If the patient's on supplemental oxygen all the time, is still it's still a good idea for them to do?
Yeah, and that's the only reason I have this slide is because I wanted to show you this first section where it says A, B, C, and D are all candidates for pulmonary rehab. There is no point in which a patient, arguably group A maybe wouldn't get as much from it, right? Because they're not even really having that much shortness of breath yet. But for sure, groups B, C, and D are all good candidates for pulmonary rehab. I've taken patients to pulmonary rehab that are on the vent 24 hours a day, and they do pulmonary rehab on the vent. And they do not like it when you do that. Pulmonary rehab is not super stoked on those patients, but they will be the more we do it, right? I mean, these people are out there. The recommendations are that all patients have access to pulmonary rehab, not the ones that are B and C, that are like, you know, able to do things and able to really get real great visible benefit from it. All patients are supposed to have access to pulmonary rehab. We know that we get benefit from it, and so we should provide them that access because the earlier patients are going to get the education that they need to hopefully prevent the trajectory from going as badly as it sometimes does. And people in Group D are not going to get as much from it, but they will get things from it, and they will improve their quality of life if they go. And they also get a lot from the social benefit of being in pulmonary rehab. There's a lot to be said for being around people who are going through what you're going through. And it's difficult to get people there. I totally get what you're saying about that. I show people videos to get them inspired. That is what I do because I feel like it's helpful because it's patient-to-patient conversation, you know, that seems to help. I'm going to show you guys this video, and you're going to have links to it so that you could use this as well to help talk to your patients about it.
I guess one other thing I would say about exercise and the COPD patient, a lot of times I'll have a conversation with them, you know, athletes, you know, professional athletes don't have super hearts and super lungs. They just have muscles that are trained. Okay, and exercise physiology applies to this population just like it does to any other population. So if you're not using your muscles, you're going to be more short of breath. So you got to get your muscles in shape, and the way to do that's exercise, whether it's pulmonary rehab, walking 3 times a week, going to the mall, whatever that is. They seem to get that a little bit more, and they understand that instead of sort of talking above them. If you just talk about a professional athlete having well-trained muscles, they kind of get it.
Thanks. I guess I wanted to know specifically, like, where are the patients ending up? Are they in the hospital? Are they in a physical therapy location? Like, is there limitations when we do a referral? Is there limitations to people getting into this? Maybe you're going to get into that.
No, I was just going to answer. I was thinking I never answered your question as he was talking. So right now, here's what's in the community. Legacy has, each system seems to have their own pulmonary rehab. Legacy has one, OHSU has one, Adventist has one. Who am I forgetting? Providence has the one at Gateway, right? So I think those are the only 4 in the community that I know of. We do not have a home-based pulmonary rehab program. It is not that it wouldn't be as effective. There's no literature that says it would be less effective. It's just not something that this community has, or I don't think very many community have. Physical therapy, I see oftentimes ordered in place of pulmonary rehab for people. I think that that's better than nothing. I think it's very difficult to get people, as we all know, it's very difficult to create an exercise routine when you feel good. I've struggled with the entire life, most people have. So when you don't feel well and there's nobody standing over you encouraging you to get up and do an exercise program in your home is not as easy as you might think. And so getting people to a community-based system, if there's not going to be something to come to them, getting them to this is really helpful. And it may take several times. You know, ordering it, they have things happen, they may have to go back and do the intake several times before they actually complete the process. I've seen that, you know, and that's okay. They're not usually in physical therapy. It's usually within a hospital that they're being held. Is that true, Dr. Cummings?
Yeah, well, I mean, just while we're talking about it, I just Googled it and looked at Portland's pulmonary rehab locations. And primarily they are located in the bigger hospital systems or nearby. But there are others that might be a little bit closer to, you know, the barrier is going to be getting the patient in, right? And so you kind of, you know, might have some of your staff understand where on the map these are located.
And they don't have to be in that system to go to that pulmonary rehab. So like if you have a patient that's close to Good Sam, they can go to Good Sam and not use Legacy for anything else. So we can play that number one, part one. These are combined about 9 minutes long, but worth your viewing and worth keeping around for your patients.
Or maybe not.
You could just, you guys just talk amongst yourselves for a moment. Just Google or just search.
Let me get
While we're waiting on that, there are a couple things I wanted to just make a point with respect to Heather's presentation. Oxygen therapy, I think you cannot underestimate the importance of documentation of what their flow rate is in the clinic. It's just part of the vital sign in a way. That way you know what their baseline is. Remember, oxygen is one of the 2 therapies that improve survival, right? So why wouldn't we know what the dose is, okay? The other couple of things, we talked about the exercise. I did give my little 2 cents on that. Phone triage. Sometimes it's important to have the MAs maybe not necessarily overthink it, but to get the major data that's going to be going to the provider, which would be how much more short of breath you are you having wheezing? Okay, those 2 things are sort of going to dictate prednisone or not, okay? The other thing that you're going to think about, do you have fevers? Do you have sputum color change? Those are the things that are going to key you into starting an antibiotic. And many times the patients don't understand that they can call the provider's office instead of going to the emergency department. So that's part of the spiel I give the patient. We have someone available 24/7. If you feel like that you're having difficulty, call our office. We can oftentimes deal with these things over the telephone, keeping you from having to go to the emergency department. Okay, so that repetition of telling the patient to call first will keep them from going. Oftentimes.
You know, we're talking about one of the things that I think is really helpful, and you may have said this partly, but having your patient with COPD have a phone number to call, whoever it is. Ideally, it would be either their specialist, if they have a good connection and they're already connected with a specialist, or your clinic if you're comfortable. But as soon as they start having symptoms, to call, have a way to actually talk to a person. They won't wait for 6 or 8 hours for a callback. It has to be pretty immediate response time for that. Cool. Hi. Got some prizes. So that's a long video, and I'm aware of it. I think it's really important, though, that we see how that looks from the patient perspective, because we use words that are triggering when we talk about pulmonary rehab. Possibly exercise is possibly a word that, according to these people, is like something they've already shut that door in their mind. So getting them to reopen that door is we're gonna have to change the color of the door. We got to change the way it looks. We got to change what they think exercise is going to look like and what pulmonary rehab will look like. So hopefully you guys like that. We only have a little time left, so I'm going to go to what I think is the most important thing. So this is a list of all the equipment that a COPD patient will likely end up with in their home. And keep in mind that their home is oftentimes very small. Like, we're not talking about people who have large 2,000 square foot homes, right? We're talking a lot of our patients are living in a one-room apartment. And they have a concentrator, they have tanks, oftentimes they have an e-tank, which is used as their portable system, which we'll talk about a bit, but they may have 15 of these tanks in their house as well, like somewhere shoved in a corner. They'll have a nebulizer, BiPAP machine possibly. They'll also have a walker, bedside commode, shower chair. At some point they probably had a manual wheelchair, which they still have, and they have an electric scooter possibly. So that's a lot of equipment. My original thought was I'm going to bring all this equipment in, and put it in the corner so you guys can see it, and then I realized that I have no point with that because we know that we give a lot of equipment to these people. We know that we're overwhelming them with all the stuff that we're throwing at them. I guess my point to this would be that we're just continue to be aware of it and how overwhelming it can feel when they come into the clinic or into the hospital. They just have what's in their hands, but their life is back at their apartment, and it's sometimes a mess. So realizing that that can be very confusing and a lot of things to take in when we're educating is helpful. One of the things, I'm talking about DME because it comes up so often that people are so distraught with the process of getting DME equipment, getting it serviced once people have it, getting good service for their members, right? So here's some recommendations that I would give you, you can use these or not. I would really recommend, there's probably 5 or 6 companies in this area, and I'm not going to say one's better than another. Some are good on some days, some are bad on some days. It really is not about what company you use. It's not about me saying what company to use. It's about your clinic deciding and really maybe narrowing it down. You don't have to support every company in the city, right? Sometimes people feel obligated to rotate their patients through. Figure out who you like and develop a relationship with those companies. It can be one DME company that you really love. It can be a couple so that you have some choices. But talk to your patients about who they like. I gave you an example of a questionnaire that you could use. You can do anything you want though. Ask people questions. Do you have medical equipment in your home? Do you know how to contact? Do you know who provided it? If they don't know who provided their equipment, that's a red flag, right? Because they're probably not in any kind of communication with them. Do you know how to contact them, and do you feel satisfied with your service? Those are really vague questions, and you can ask people those questions and try to get some input about whether or not they're happy with their company. It will help you a lot to narrow down who you deal with. My other recommendation would be that you have one person in your clinic, and a lot of you already do, that does DME, and have that person develop a relationship with somebody in the companies that you choose to work with. There's some accountability there. It helps them feel more obligated, possibly, to follow through, and it just gives you a quicker stream. As an example, I did a hospital discharge that took 57 phone calls, and that's not an exaggeration. And I know what I'm talking about, right? And it took 57 phone calls to get a patient home on a ventilator. Now, that's a ventilator, but it's not that uncommon for other things. It takes a lot to get DME going and to get it correct and to make sure people have the right thing once they get home. So just keep in mind that sometimes it helps to kind of narrow it down a bit. So we're not going to go through the other stuff on this because we don't have time, but I do want to talk about oxygen really quickly because this is the one that comes up the most as a problem. Couple of things. So there's many ways to order oxygen for your patients. You can order it with exertion only, you can order it for nighttime only, or you can order it for 24-hour use. And that's going to be determined by how the testing is done. And I'm not going to go into the specifics of how to do the testing because it changes pretty frequently, and I would recommend that you pick your DME companies, get them to tell you exactly how they want the testing done, how they want the paperwork done, so that you can really narrow it down so that it's not so time-consuming. But when your patient is ordered to have oxygen at home, they're going to get a concentrator, right? And that's what this is. Can everybody see this? I can't pick it up, it's too heavy. So this is what they use in the home to make oxygen. So this pulls in room air and produces about 92 to 95% oxygen. Okay, the oxygen is going to come out right here. So this is just like a regulator, except for it's not going to put out 100% oxygen, right? So in the hospital or in a tank, you're getting 100% oxygen. With this, it's going to be less purity because it's using the room air to make the oxygen, and the higher the liter flow, the less purity. Okay, so if you have a patient on 2 liters per minute, they're going to get a lot closer to that higher percentage, versus if you have a patient that's maxing this out at 5 liters per minute, they're going to get less. So keeping that in mind. 5 liters at home is not the same as 5 liters in the hospital, often, okay? If you order 24-hour oxygen, you just say, I want my patient to have 2 liters per minute 24 hours a day. Most likely what your patient is going to get is going to be this, and then a E-tank with straight flow with a regulator that blows oxygen continually, and a lot of these tanks, right? And that's a big system. So the patient is expected to carry this around with them, right, and just pull it around. Unless you specifically say, and this is probably one of the most important things regarding oxygen, unless you specifically say for them to be tested for a conserving device and a portable oxygen system, this is what they'll get. And nobody will bring it up because the patient doesn't know that there's any other options unless they see it on TV, and the home care company is not going to bring it up. They're not going to. They don't make money, and this isn't against the home care companies. It's just the fact they're working within the same constraints as everyone, but they don't make money off a smaller system. This is easier for them to provide, and it's easier for them to service. So we have to make sure that the patient's getting the right system. If you order a portable system, your patient will get a couple of options. This is a tank system that they'll use, and it's just got a small tank inside of it, and the oxygen only comes out when they take in a breath. So it makes the tank last a lot longer, but you should have your patient tested for this. You shouldn't just order it. You know, some of the companies will say, just tell us what liter flow you want to put the conserving device on, which is the different regulator that only gives oxygen when they take in a breath. You want to have your patient tested to make sure what liter flow they need for that, and all you have to do is order it. You just have to write it on the order when you send it to the home care company, test for an oxygen conserving device. They know what to do with that, and they'll follow through with the rest of the process. This is a surprise to me as well, but this is a portable concentrator that one of our local companies, so Northwest Medical provided this for us, by the way, to give them a plug. But this is a portable concentrator that they say, and I made them like answer this 5 times yesterday because I just almost don't believe it, but they say that this is available to all of our patients now, and that they just have to qualify by being able to tolerate being on a conserving device, and that they can get this portable concentrator, which has not been the case in the past. But I told them, I said, I'm going to a room full of people, and I'm going to say that. And so you're going to get orders, because this is like, portable concentrators are a big topic. People ask for them all the time, and up until this point, mostly only patients that have dual insurance have been able to get this. So it's a good option for your patients, but you have to ask for it again. Anybody have any questions about oxygen? I think I'm out of time.
We got time for one quick one, and then we're going to have a break.
This might be for Dr. Cummings too. What is the data on, it improves survival benefit. At what level of oxygen are we getting down to before we get that survival benefit?
Okay, so the question is when to prescribe based on predicted improvement in mortality. Recent literature does not support testing anyone at night or ambulating that has a resting saturation of 94% or better. So if they're in clinic and they're on room air and they're satting 94% at rest, you're not going to change their outcome by walking them around or ordering an overnight oximetry study. Okay? Compliance, like inhalers, is difficult. How many times have you heard, boy, I'm out walking around and then I get really tired, I go sit down and I put my oxygen on and feel better. And, so the education part of when to wear it with activity is one of the barriers, okay? I found that sometimes I'll just tell patients, if you're prescribed, just wear it. Just wear it all the time, because the time you're going to need it most is when you are active or when you're hypoventilating, which happens relatively, happens at night, relatively speaking. So if, the magic number for tissue delivery is right at 87, 88%, okay? That's where we want patients to be, so the titration for the oxygen is 88%. Okay, so if you have someone in your clinic that you're ambulating to try to get to an adequate dose of oxygen, 88% is what you're looking for.
Great, thank you. We have to be mindful of time, folks, so we're going to give you a quick 5-minute break before we move into the other segments. Please give a huge thank you.
I want to say one more thing.
To Heather. She's got one more thing to say.
So important. I swear I will not talk after this. So when people get discharged from the hospital, this is what I see a lot. They get tested. They've been on oxygen for days. They get tested sitting in their recliner, in their room, 92% room air at rest, they get discharged from 24-hour oxygen to nothing. And that's a person who's below the 94% at rest, right? So those people, we want to be thinking about those people. If they were on oxygen in the hospital and they're hovering at that 92, 93% at room air at rest, we should be testing those people at night. And you can do that through any of your local DME companies. They can all do that test for you. Okay, thank you.
Okay, we'll see you in 5 minutes, gang. 5 minutes and we'll continue.